What's up, everybody? Eric Jonas here for PT on Ice, and today we're talking about the acromioclavicular joint. Acromioclavicular joint pain, not the most common source of shoulder pain in our patients, but we do see it from time to time. And so that joint, over time, it's pretty normal for wear and tear to occur, right? As we age, we will see degenerative changes of the acromioclavicular joint. That is totally normal. And so you could have a shoulder MRI or radiograph for another reason, right? There's pain in another region of the shoulder, or there's another clinical thing going on, and you just happen to see these AC joint changes. I would not get worked up about that. I would not go and target the AC joint right away. So my point is there are a lot of normal age-related changes, joint erosions, maybe mild effusion, wear and tear, joint space narrowing. That's totally normal. But if the patient presents with signs and symptoms that match acromioclavicular joint pathology, then there are some things that you may want to do to address it. So we would expect, that where that clavicle articulates with the acromion, we would expect to see pain with some degree of horizontal adduction. So that's compressive to the AC joint. So when horizontal adduction reproduces your symptoms, that's kind of one thing that makes you think AC joint. Obviously, pain right in the region of the AC joint would be another one. And if we come in here and we glide or we manipulate that a clavicle on the acromion and that reproduces pain right there, right under the AC joint, then that will be another indicative. And obviously, there's a number of other clinical examination techniques that you would want to perform. But the bottom line is if you suspect AC joint involvement, you're going to want to do a few things to hopefully calm that joint down and then progressively load them and progressively exercise them to be able to recover. So manual technique wise, traditionally we would always teach gliding that joint. And so the joint's oriented in this kind of posterior medial anterior lateral direction, and so you can grab the clavicle and you can push it posterior medial, and I feel it move there. I can kind of wiggle that joint there on Cindy's shoulder. I can pull it anterior lateral. And so that's, a traditional kind of glide of the AC joint there. But what really works better, or what's a nice way to approach this, is anything you can do to gap that joint, open up that AC joint, because it's compressive. Side sleeping hurts, pressing movements hurt, anything that kind of compress that joint hurts, and we want to sort of facilitate opening up. So take anything you have that's soft and rolled up. This is just an ACE wrap would work great. Towel rolls would be wonderful if you have a relatively small towel roll that's taped up. And you're going to place that just medial to the scapula, kind of between the scapula and the thoracic spine along the first few ribs 2, 3, 4, 5, that kind of region right there. And what that's going to do, that's going to be a fulcrum that you're going to use to kind of open up that AC joint like that. And so as I've got that fulcrum under there, it has to be a soft, comfortable fulcrum. That's really important. I wouldn't want to use a wedge or even a small foam roller or something like that. That wouldn't be as comfortable. I want to use something soft. But I'm going to come in and I'm going to grab that clavicle again. And so I'm pinching the clavicle and I'm coming as lateral as I can, as close to the AC joint as I can. I can actually palpate the AC joint right there. And then what I'm going to do is I'm going to press the shoulder girdle, the scapula, and the acromion posterior while grabbing the clavicle, trying to kind of gap or separate that joint. And so I want to do that to sort of create some relief. I want the patient to feel that sort of sensation of kind of pressure being taken off the AC joint, because then we're going to facilitate that with some exercises. And so it's opening up that joint. I might even in some cases kind of facilitate or almost be pulling that clavicle kind of in an opposite direction or medial as I'm pulling the acromion lateral, facilitating an opening. I don't think biomechanically you're actually doing that. The idea that you're getting your hands in there and actually separating that joint is probably a little far-fetched, unrealistic. But what you are doing is creating a neurophysiological effect, and that sensation of that gapping is probably what helps a little bit in pain modulation. So that is one thing to start with. And then what I want to do is really teach opening techniques. And so the nice way to do this is if I put my hand underneath the scapula, and I'm just going to say, I want you to draw your shoulder blade back into my hand. So she contracts her periscapular musculature to hold back there. I might even kind of give a little overpressure, hold back there like that, good. And I'm providing resistance with this hand. So this hand gives a bit of a cue to give you that isometric resistance there. Push back, push back, push back. Perfect. Push back again. Hold. Great. I can couple that with external rotator contraction, so we're going to do that again. So push back, draw back, and then I fire her external rotators at the same time. So I've got this concurrent scapula retraction, open up that shoulder joint, fire the external rotators. So that's all done kind of down low, the arms by the side. It's not really a position of provocation. What I want to do eventually is we get better and better at this. Perfect. Eventually, I'm going to bring that arm out into higher angles and higher planes. And so we're kind of come up here, and now I'm going to have you do the same thing. Draw back, and then now horizontally abduct. So push, 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 push. Good. And so I'm going to give her resistance and cueing to kind of come out into horizontal abduction, and I'm just going to slowly chip away and increase that coronal plane abduction angle as she presses, brings back. I find a position that she kind of has trouble with. I'm going to hold there, keep it there, don't let me move it. Don't let me move it. And I'm going to add resistance underneath the scapula there. Perfect. I can add a little bit of a deltoid contraction, bring it back. Don't let me pull down, don't let me pull down. Good, bring it back. Excellent. We can get up in this position and do, I've shown before, a lot of these abduction shoulder mobs where I'm coming in, grabbing the scapula and distracting the humerus, opening up that sort of axilla, and then come up into the overhead position and contract. Perfect. Good job. Awesome. Hopefully that is helpful. Check me out. If you go on our website, I teach the extremity management course. 2 days we cover kind of all things shoulder, elbow, hip, knee, foot, ankle, and just really the common conditions that you see in the clinic, manual therapy techniques, and then a ton of exercise progressions and things that we can do to help people recover from these different conditions. All right, take care, everybody.